Hi, welcome to Cardiovascular Innovations 2020 Digital. I'm João Cavalcante from Minneapolis Heart Institute, and it's an honor to present here on behalf of our group on this topic of sorting out aortic stenosis and its impact in the myocardium. These are my updated relevant disclosures. The 2017 expert consensus for management of patients with aortic valve, and particularly aortic stenosis, through transcatheter have recommended the use of cardiac MRI for the identification of cardiomyopathies, for not only understanding the disease of the myocardium, evaluation of myocardial ischemia and scar, but also understanding the fibrotic burden, which might be important, as we'll see, in the outcomes that these patients will have despite having successful transcatheter aortic valve replacement. The uniqueness of cardiac MRI is such that it provides evaluation of function remodeling, it provides evaluation of the aortic valve flow and morphology, it provides also evaluation of myocardial perfusion and coronary artery disease, which is common in these patients, evaluation of 3D anatomy without the need of gadolinium, which can provide a 3D evaluation, particularly important for patients with chronic kidney disease. 4D flow is some exciting new development that might provide us the capability to be almost like CT with unrestricted planes, although the spatial resolution is not as good. But obviously where MRI really earns its money is by the capability of tissue characterization with evaluation of replacement fibrosis vis-a-vis scar, replacement scar, interstitial fibrosis, which we'll talk about here, which is not necessarily what we can see by LGE or late gadolinium enhancement, but the interstitial expansion. And an exemplar of that would be the cardiac amyloidosis, which is something that actually is quite common, as we'll see. The most important paper that has come out in the last couple of years has been this one by a large cohort of almost 700 patients from UK. Scar, assessed by late gadolinium enhancement, was present in half of these patients, either infarct-related scar or this mid-wall non-ischemic scar, typically associated with increased LV wall thickness. The presence of scar doubled the all-cause mortality and tripled the cardiovascular mortality, regardless of the etiology, infarct or non-infarct, and regardless of intervention, either SAVR or TAVR. And it was not only whether you have scar or you don't have scar, but actually the quantification also mattered. There was a proportional increase to their mortality despite successful TAVR. And we had the chance to write this editorial along with Paul Saraja from our Minneapolis Heart Institute by saying that it's not that we're intervening too little or providing too little benefit to intervening too late, but could we do a better job in trying to intervene even before the scar is there? And this is a work that Dr. Mark Dweck from Edinburgh is leading. They're called the EVOLVED trial, taking patients that are asymptomatic with bona fide severe aortic stenosis, putting through the MRI after pre-screening for decompensation with EKG and high sensitivity troponin. If the MRI shows a scar mid-wall fibrosis, they'll be randomized to early surgery or TAVR, or the current standard of care, which is watchful waiting. And by doing that, perhaps by triggering intervention at the presence of scar, we might be able to revert this prognosis or do even better. This is a paper that we had the chance to write together by showing that as the aortic stenosis progresses here on the x-axis, the cellular hypertrophy takes place, this diffuse fibrosis starts to creep up, and then further later on the replacement fibrosis. And if we keep watching this replacement fibrosis, it will grow over time. Once AVR is done, it actually will reverse some of this hypertrophy by relieving the afterload. The cell mass will regress, the diffuse fibrosis, but that scar is not going to go away. What we're talking about here is this concept of cardiac cirrhosis. We talk a lot about interstitial lung or liver disease, but interstitial heart disease is what we now can measure and we can see by this cardiac MRI. This is a normal patient. This is a patient with severe aortic stenosis with that interstitial expansion between the myocytes. And now we can measure this non-invasively by cardiac MRI by measuring something called extracellular volume fraction. That comes before the scar. and that could be a signal that the ventricle might be at jeopardy. This is work that we did when I was back in Pittsburgh, looking at patients, about 113 patients with aortic stenosis. We see that a normal ECV should be around 24 plus or minus 2. In patients with aortic stenosis, yes, as we would expect because of the remodeling, we have a higher ECV. However, there is a spectrum of disease in such a way that patients with normal ECV, despite severe aortic stenosis, had no events at 1 year. So could these patients be the ones that we can watchfully wait more carefully, as opposed to those that even in the absence of fibrosis might be at risk? This was validated in a larger cohort of about 440 patients, including also a group from Pittsburgh, showing that the increase in ECV corresponded to a proportional increase in all-cause mortality, despite these patients receiving aortic valve surgery or transcatheter aortic valve replacement. So that might be a marker even before also the myocardial replacement with scar. But what also could be driving the increase in ECV? This is a case that we had referred for TAVR, 88-year-old, transferred with progressive fatigue and dyspnea and exertion, had a murmur, systolic murmur, had HFpEF, atrial fibrillation, diabetes, preserved ejection fraction, and then low gradient aortic stenosis. And in the calf, no significant coronary artery disease. When we look at the echocardiogram, we can see that there is diffuse increased wall thickness on both the left ventricle as well as in the right ventricle. Despite preserved ejection fraction, there is low forward stroke volume and low transvalvular flow and a low valve area, with mean gradients ranging anywhere between 28 to 35. So low flow, low gradient, preserved ejection fraction. So-called paradoxical low flow, low gradient. When we look at the strain, myocardial strain by speckle tracking, we could see that the apical segments had a relatively preserved strain, normal being around minus 18, minus 20, and whereas the basal segments were not so good, they were compromised. And this has been reported previously in cardiac amyloidosis. So could this be the phenotype? We took this patient to the cardiac MRI, and we can see that the patient is in atrial fibrillation, there's a small pericardial effusion, and there is the aortic stenosis there. But when we look and compare the cardiac MRI late gadolinium enhancement images, we can see that patients with severe aortic stenosis without any scar should look all nice and black, and in this patient was all diffusely infiltrated in both atria, both ventricles, and a small pericardial effusion. And when you see that, that is cardiac amyloidosis until proven otherwise. And by looking at different now scanners, both speckle tracking, technetium pyrophosphate, and cardiac amyloidosis, we can actually diagnose this much more. And several studies have shown that this is not uncommon. And this more recent one here by the Columbia group that did PYP, about 1 in 6 patients, 16%, who received TAVR had that cardiac amyloidosis, more commonly in the octogenarians, males, and this low flow, low gradient. And cardiac MRI is a great test because it can also separate the phenocopies. It looks like, but it's not. So is this HCM? Even though there is asymmetric septal hypertrophy, this patient had a prior infarct in the infralateral segment. And you can see when you do get the gadolinium, there's diffuse infiltration in the atrium on the ventricles and the right ventricle. So this is actually not HCM. This is cardiac amyloidosis. And also another patient that we had recently that had actually significant severe aortic stenosis, not low gradient, received a 29 sapien 3, and recurred with heart failure. You can see that the valve is working well, but there is diffuse cardiac amyloidosis. So, and patient had a bone marrow biopsy, which showed actually 35% plasma cells and multiple myeloma. So not everything that is old is going to be transthyretin. It's important to go move a step forward so that we can better understand. Definitely more evidence is needed in the management of these patients that have the overlap of aortic stenosis and cardiac amyloidosis. The number of patients that we have seen in this overlap and we have reported before is still small, but perhaps the valve that we wanted to choose should be one that causes less paravalvular leak. They don't typically tolerate paravalvular leak, and they tolerate a pacemaker. And a couple recent studies from UK showing that perhaps actually TAVR might be a life-saving strategy for these patients. Even though the numbers are small, patients that receive TAVR do much better than when they do not receive TAVR. And perhaps that could be a new paradigm shift now that we have drugs that can treat cardiac amyloidosis. And if you're interested, I would welcome you to contact us. We're setting up a registry for that. Obviously, MRI, as I have been talking all along, it's not scalable, but could we use then the CT that we do for TAVR planning to measure that ECV? And if that ECV is going to be elevated, as we would expect in the presence of cardiac amyloidosis, could that CT be also be a way that we could detect this process? And this is a work by Tom Tribal, who is my colleague from Bart's, showing that in patients with aortic stenosis that we have a slightly higher ECV, as we show by cardiac MRI, but look at patients that have cardiac amyloidosis have a significantly higher ECV, and this was not in the presence of AS plus cardiac amyloidosis. But more recently, we have been working together on this cohort, and we found that this ECV, when it starts to go above 31%, amyloidosis is highly possible, and we can see here that this ECV by CT has a very nice correlation with PRIP, and this was recently accepted to JACC imaging, and perhaps that could be our strategy that we wanted to use in this screening evaluation of these patients. So in conclusions, in the context of aortic stenosis management, TAVR, for TAVR particularly, CT and CMR provide important contributions. Aortic stenosis is definitely a disease of not only the valve, but the vessels and the myocardium. CT has transformed the way we approach. Ejection fraction is not enough, and strain could be upstream. And assessment of strain can be done by both echo, also by CT and by CMR. Fibrosis, when present, doubles the mortality. Should we intervene before its development? And lots of work has been done. And the cardiac amyloidosis, which is common, could be associated with worse outcomes, asking, could we do pre-TAVR screening for these patients? And with that, I would like to conclude also acknowledging our great team that we have of postdoc research scholars, our CMR lab and our CT lab, and also many other collaborators. Thank you very much.